afraid I can't keep to just one actually, so I'll have a number. The first one was the advent of vitamin D metabolites to treat renal bone disease. Before that, children were severely incapacitated by the bone disease and often had severe myopathy. And it's quite dramatic when they got the treatment with 1-alpha and other metabolites. And the next one was erythropoietin. Children used to run with hemoglobins of 3 and 5 grams on dialysis, and we used to debate whether to actually transfuse them at all. And it must have been a remarkable improvement for them when they could get the hemoglobins up to 7, 8, 9 and 10, quite a new thing for them. In the early times of dialysis, and I looked at this across the country, paediatric renal services tend to be diffused over a number of sites. In Manchester, the dialysis was at Booth Hall, the acute renal failure renal biopsies was at Pendlebury, the renal transplantation vascular access was at the MRI. And I actually think bringing all the paediatric renal services together on a single site, it had some disadvantages, but was, from a paediatric nephrology point of view, the most important thing that happened in my career. I'll touch on that again a bit later on. And the other thing is we should never put paediatric nephrology outside the context of children's services altogether. I was chairman of the Regional Paediatric Subcommittee in the early 80s, and we approached the Regional Health Authority to say the arrangements for paediatrics were not adequate. And the regional medical officer told me there's no way that could be resolved, and asked us to set up a committee and to report 6 months later in December 1985. And we came up with a plan then which was actually supported unanimously by paediatricians throughout the region. But of course it took till 2012 for that to actually be put into operation. Because before that, despite all the children's services and renal services being on one site, every new advance, particularly in imaging, was much later coming to children's hospitals. So I'd be going to district hospitals where there's ultrasounds, gamma cameras, MRI scans, CT scans, and the children in the children's hospital weren't getting that, and I'm sure that will continue in the future. Not to mention there's also all sorts of other relationships which are important as well, but from that point of view it was really a big disadvantage really. And within that we must remember as well that charities were extremely important, and Ian was much more central to charities than I was, because we wouldn't have been able to move on to a single site if it hadn't been for support, charities buying gamma camera, building a unit for us. So I think that was an important element of paediatric nephrology at that time. Well, initially there's resistance from general paediatricians. I remember, and Ian will remember this patient well, I won't mention the name because I think it's inappropriate, but she was on acute dialysis at Booth Hall in 1974. She had rapidly progressive glomerulonephritis. It was the first patient that went on to peritoneal dialysis in Manchester. And even though she was on dialysis, the general paediatrician thought he retained overall control of this patient. And it was a recurring theme that when you actually went to see patients, they were happy for advice to be given, but for you to take patients over from them was not very acceptable to them. In fact, it was frequently told that you took all the interesting patients off them. Well, I thought all patients were interesting, and actually, and there are some, again, disadvantages in actual specialisation, which I'll come on to later on. I think as specialisation in paediatrics developed and became more extensive, it became much more acceptable, and the generalists I think are now looking for a role really, probably. But early on there was some resistance, particularly from general paediatricians who didn't have specialist interest. Well, Ian's touched on that to some extent, and the relationship between Ian and Netta Malik were actually extremely close and very supportive of each other. Ian had this joint adolescent clinic with Netta, which I suspect might have been the first in the country and has never been actually noted as much as ought to have been done. We shared dialysis patients then, so there's a weekly meeting where the adult nephrologist came as well. There's a weekly transplant meeting we went to as well. And there were, I think the peak of that relationship came about the mid-1980s when John Feely was around, who of course went on to massive things nationally and internationally subsequently. One of the best colleagues I've ever worked with, an absolutely delightful person and a fantastic nephrologist. And he and John Feely, because I think the final outcome of this relationship has to be research so you can improve care. And John Feely and Jim Beattie, who did a lot of work in Scotland subsequently, produced some really high-class research at that stage. Thereafter, and I think this part related to the actual movement onto a single site, because then we have less contact with the adult nephrologists. More adult nephrologists come on the ground as well. More units open. So although the relations always remained cordial, they weren't as productive as they had been before. And it was much more patchy. There were certain units in the region who were quite antagonistic, others were extremely supportive. There's some excellent relationships. The relationship with Donald O'Donoghue at Hope Hospital was outstanding. And we did run a joint adult paediatric meeting for about 10 years or so, where we looked at issues across adult and paediatric nephrology. But I think part of the cooling is too strong a word. Part of the less collaborative relationship was because we'd now become isolated on the children's side. Paradoxically, the relationship with the transplant surgeons became much closer, and I think that was as a result of this. And by accident, I was out with the transplant surgeon for lunch last week, and he described the relationship with paediatric nephrology as the best professional relationship had in his working career, which I thought was really interesting thing to say, really. When I ran these questions past my wife, she said the children were the people who inspired me to set it up. And of course I didn't set it up because Ian was already here at this stage and had in place the elements of the renal service. I think what I did, because it was so disastrous from a children's point of view, was actually particularly pressure ahead with the idea of getting the unit onto a single site. There was opposition, quite strong opposition. Booth Hall, I remember going to a medical staff committee meeting there and being thrown to the wolves because they were all howling to keep haemodialysis at Booth Hall. One of the people who stood up and spoke out then to say it was important for this time was John Curiel. A lot of people know him, he became a very important respiratory physician in Liverpool. The adult nephrologists actually, particularly Netta, took the view that actually it was good for the adult unit to look after a small number of children. Well, it might have been good for them, but it wasn't particularly good for the children, so there's some opposition from that point of view. There was strong support from Bob Johnson to move ahead, and I think about the tennis court oath. Those of you into history will know that in June 1789, when the States General were being disbanded by the King, they collected on the tennis court in Paris to put an oath together to say that they wouldn't disband until there'd been a new constitution for France. Well, as the issues about bringing paediatric nephrology onto one side and bringing transplantation up here developed, Ian organised a tennis court meeting for us. We met at the Northern Lawn Tennis Club with Bob Johnson and support from the paediatric surgeons as well. David Goff came along, and that was really the point at which we began to move things forward. Quite interestingly, and I never thought this was likely, there's one particular episode which I won't go into, which convinced me of the absolute essential need to get children onto a children's site. And Bob Johnson last week mentioned the specific name of this child to me, so it had the same effect on him. We'd never discussed that subsequently at all, so it showed that that episode also had quite a significant effect on him. I thought a lot about this. And I think the most important message that I could give is learn how to get the best out of a team. In medical management, the recurring problem is dysfunctional teams. Every hospital has them, and the consequence is unhappy staff, poor results, and bad results for the children as well. And I think as juniors, you must look at that, and I think not go on courses, but look at different teams and see how they work. And observe what's good and what's bad in it. Thinking about this over lunch as well, it seems to me as you become more senior and get into a team where there might be conflict or where you might feel a bit isolated, it's very important to identify one or two people who you respect, and you can go and speak to them and will give you clear advice about whether it's your fault or whether there's something else that needs dealing with. And I think when looking at teams, it's important not to think one size fits all. Different teams work in different ways, and at different stages, different units need different sorts of teams. You know, to be in a team doesn't mean you like everybody, it's just mean you've got to get on with people. There are times when teams have got to have a period of kind of being fairly easily getting on with each other, but a complacent team is just as much of a problem as a dysfunctional team. So there's time when you need strong leadership, there's time when you need more of a collaborative approach to team membership. And I think it's so important in nephrology within the consultant and also with the other multi-professional staff as well. I think if you look back historically, both in this country and internationally, paediatric nephrologists have taken a disproportionate interest in larger medical management issues. I mean, Cyril Chandler, Stuart Cameron before him, various other people. And I think that's because team management and membership of team is so fundamental to nephrology, probably more than most other specialties in nephrology, so that I think there's added value to being members of a team and learning how to, because you can move on to a wider field if you want to. Well, the area I particularly developed was psychosocial research. Medical advances had resulted in considerable improvements in life expectancy, but what were the costs in terms of the quality of life for the child and the family and the child's psychiatric adjustment? Even the most successful treatment had its burdens, and I felt there's an obligation to identify the burdens of the condition, its treatment, and so that all available social and psychological support and treatments might be provided and appropriately targeted. I think it's very important as well. First of all, that's a never-ending job, because the actual problems change as the patient population changes, so you need to be looking at that all the time. At the time as well, I mean, there's an issue that people can over-psychologicalise things, and before you know where you are, every child is on dialysis, have a psychologist, which I think is completely unnecessary, really. Before, as well, there's a tendency for psychosocial research to actually be dominated by anecdote as well, and we wanted to move very much onto much more systematic collection of data, use control groups and other things like that. And if you're not very careful, there are fashions in things. I remember when growth hormone was coming along, that suddenly everybody was saying that growth was the most important determinant of long-term adjustment in renal failure. Well, none of our studies had shown that. I didn't expect growth hormone to be as successful as it was, and there was a concern that it would actually increase the actual anxiety about short stature of children with renal failure. In the event, growth hormone was remarkably effective and most children grew better. But actually there's a subset of children who didn't grow with growth hormone, who were actually often the most severely growth retarded, who didn't grow, and their concerns of growth did actually quite significantly increase as a consequence of that. So that was a completely unexpected finding to me, that actually we'd expected to see much less effect of it, in which case the concerns raised as a consequence of this intervention might have been much wider. So every study we did made me rethink about some aspect of care in a different way. Well, this is where Kath said it was the children, and I suppose that's probably true. The second one is possibly Mike Dillon, though I don't know whether anyone will confirm this or not, because Mike tells me sometime afterwards that he was actually approached for the job in Manchester that I got. But eventually Great Ormond Street offered him gave him a better offer, so he stayed there. I was an accidental nephrologist. I mean, if I hadn't got the job in Manchester, I would have actually probably gone off and done general paediatrics. Ian was the ideal colleague, really. First of all, the skeleton of the services were there. Ian's interest, much more, as he said before, were glomerular tubules, and mine were more patients and dialysis, really. And he largely let me get on with that, but supported me when necessary, really. So I'm grateful that Ian gave me that job, and I don't think we ever had a cross word in all the time we worked together, really. The other person who had a great impact on me was a neonatologist called Pamela Davis, who I worked for at the Hammersmith, which in those days, well, before I went anyway, was probably one of the premier neonatal units. She was a woman of immense kind of gravitas, enormous support for junior doctors. One thing I used to remember was that each consultant at the Hammersmith had a postnatal ward, and Pam would waft round this ward, laying her hands on the patients, and they all felt so much better afterwards, really. An example of what she did, I mean, the Hammersmith was quite a cutthroat place then, and we had a grand round on a Tuesday morning. The case would be selected on a Monday, and you'd go around to Pam's office afterwards and say, what do you know about this, Pam? And she'd say, oh, nothing at all. And about quarter of an hour later, a whole pile of papers appeared for you, which you had to learn overnight. And then she'd actually ply you with questions the next day on the ward round to make sure you could answer these questions, which I thought was really a nice thing to do. And the people who'd worked with her, she kept contact with them throughout the rest of her life, really. It was really... So I think I learned a lot about her, from honesty, supporting junior staff. And also that unit wasn't the best of units, but Pam never directly criticised any of her consultant colleagues at all, really. So Ian and Pam Davis, I put the people who I had the biggest influence on my career. Again, I was a little bit hesitant about answering this question, but I met with my closest colleague from the Children's Hospital just before, and she confirmed my concerns about this. An unforeseen consequence of specialisation has been the danger of orphan patients, really. Patients without anybody leading them at all, multiple subspecialists coming in, all giving their advice about things but not coordinating that advice in any way whatsoever. Lack of leadership with regards to that. I've been thinking about this and wondered about whether the approach might be the generalist to come in to do this, and apparently Great Ormond Street have done that, but this friend of mine who worked there said it was actually quite a disaster, and I think the answer has to be that a subspecialist has to take control of a patient, has to offer the leadership for the individual control of individual patients. Presumably the one with a dominant problem, it might be, but certainly in my medical management experience here, it was a recurring problem of complaints, of clinical incidents, where there was not coordination, people came along, patients were left without clear plans altogether. And I think that's something that needs seriously addressing. Quite embarrassing, really. The first meeting I went to was in 1975 at Cambridge, organised by Stuart Cameron. And I turned up at the station. I was giving a paper on single needle dialysis. When I arrived at the station, there was a little sign outside saying, "Gone for lunch. Wait here, the minivan bus will pick you up." Adrian before was pointing out Stuart's sartorial elegance on some of the pictures that were out there. And this very dapper young person came in with a slight American twang to his accent. And I thought he was a student. So I talked to him in a kind of condescending way. And only later on in the evening did I realise this was actually Stuart Cameron. So that wasn't my best introduction to the SPN. The second one was to from a distance, to feel the force of the très formidable René Habib. I don't know whether the Ask Upmark kidney still exists or not, but some poor person had given a paper on the Ask Upmark kidney. And René, who was quite a big lady, stood up and said, "The Ask Upmark kidney, Ask Upmark," and sat down, which was a devastating kind of put down for the poor person to be giving this presentation.